Hi, welcome to my channel Medical Microbiology Guide. I am Dr. Udresh. Today I will discuss on the Wuchereria. The lymphatic filariasis is most commonly caused by two species, that is Wuchereria bancrofti and Brugia malai. So I will be discussing Wuchereria bancrofti today, and the common name of this worm is Bancroft's filarial worm. In 1863, the Dermack first demonstrated the microfilaria in the hydrocele fluid. In 1866, Wucherer from Basel first discovered the presence of the microfilaria in the chylous urine, and Lewis in 1872 from India, he demonstrated the microfilaria from the peripheral blood. Bancroft from the Brisbane first reported the female worm in 1876, and that is why the name of the parasite goes with his name. And Manson was the first person to demonstrate the culex as an intermediate host of Wuchereria bancrofti, and also he identified the nocturnal periodicity of the microfilaria in the peripheral blood. Coming to the morphology, the adult worm is transparent, creamy white, long, and it's hair-like. It is filiform in shape with both the ends tapering. Male is shorter. It measures 2.5 to 4 cm by 0.1 mm. The posterior end is curved and it contains two unequal spicules. Female is around 8 to 10 centimeters long and 0.2 to 0.3 millimeters breadth, and the posterior end is actually straight. So you can see the posterior end of the male is curved and posterior end of the female is straight. The lifespan of the worms is around 5 to 10 years, and the female is a ovoviviparous. That means to say that it lays an embryonated egg which immediately hatches. The microfilaria, that is the larval forms which are released by the gravid female, they are transparent with a blunt head end and a tapering tail end. Okay, so they measure around 245 to 295 micrometers by 7.5 to 10 microns, and they are covered by a hyaline sheath which is longer than the microfilaria. Say it measures up to 350 micrometers, and this represents the chorionic envelope of the egg. So the microfilaria will move forward and backwards within this hyaline sheath. Okay, so you can make out the hyaline sheath in the stained smear, as well as you can make out the sheath in the written diagram also. So there are various somatic cells, and their nuclei appear as granules in the central axis of the microfilaria. So the tail tip is free from these granules or the nuclei, and this is one of the characteristic feature which helps in the identification of the microfilaria of the Wuchereria bancrofti from the other two species. The anterior end also does not have the nuclei, and the anterior end is called as the cephalic space. So these granules or the nuclei are broken at some definite places, which acts as a landmark for the identification of the different species of the filarial worms. So there is a oblique space for a nerve ring, which we can see here, and an anterior V spot and the posterior V spot. Okay, so anterior V spot actually represents a rudimentary excretory system, and the posterior V spot, actually it is a terminal part of the alimentary canal. Usually microfilaria, once they are released, they do not go any further development. If they are not taken up by the mosquito, they usually live for 70 days, and after that they will be destroyed. They will become dead and they are destroyed. The definitive host of the parasite is man, and the intermediate host is the female mosquito of genera Culex, Aedes or Anopheles. In Indian scenario, Culex is the most common vector which acts as an intermediate host for the worm. Usually the habitat of the adult worm will be the lymphatics or lymph nodes, and why they specifically choose this lymphatics is the lymph, which is rich in the nutrition, provides the necessary requirement for the parasite. And also microfilaria, they have a nocturnal periodicity. That means they will be present in the blood between 10 p.m. to 2 a.m. and this correlates with the nocturnal biting habit of the vector. So the nocturnal periodicity reason has not been known, but various theories have been put forward, but one of the reason may be because of the nocturnal biting habit of the vector. The reservoir is always the humans. So humans, you get the infection by the bite of the mosquito. So once the mosquito bites, it releases the third stage larva onto the skin. So we know in case of malaria, if the mosquito bites, the sporozoites will be directly released into the blood. Here it cannot be so. The third stage larva which reaches the skin has to penetrate on its own to the deeper portions, or the larva can access into the skin through the bite site of the mosquito. Okay, so once it goes to the deeper portion, it reaches the lymphatics and goes to the regional lymph nodes. So most commonly the axillary or the inguinal lymph nodes are the one most frequently affected. So around 5 to 18 months, the third stage larva completely develops into adult worms. So generally the adult worms, both male and female, they live together in an entangled mess, and they cannot be separated most of the times, and so with each male worm there may be more than one female worm living together. So the once they unite, they form the female starts laying the microfilaria, which is a larval form of the parasite, and this microfilaria through the thoracic duct they reach the venules, and they will go to the pulmonary vasculature, and then to the left part of the heart, and they will be circulated throughout the body. So the mosquito, during the blood meal, it ingests the microfilaria. So these microfilaria, they reach the midgut, and they penetrate the midgut, reaching the thoracic muscles. So this takes around 4 to 17 hours. In the thoracic muscles, they become short sausage forms with a short tail, and that are called as the L1 larva. So L1 larva will molt many times and loses all its sheaths, and around 3 to 7 days it becomes the L2 larva, and at the 10th to 11th day it becomes the L3 larva, which is actually infective. So all these moltings of L1 to L3 takes place in the thoracic muscles of the mosquito. So once the L3 larva is formed, it migrates to the head of the mosquito near the proboscis. So one thing has to be remembered is only one microfilaria gives rise to one third stage larva. So the mosquito becomes infective, and once it bites a human being, the life cycle repeats. Usually the presence of an adult worm in the body will not evoke much of the immunological responses. The most of the pathogenicity associated with the filariasis is associated with the inflammation of the lymph nodes or lymphatics in which the adult worm lives. Here usually as we know, the adult worm lives in the lymph nodes or lymphatics. So once they are there in the lymph nodes gets enlarged, they become firm, and after some time they may go for fibrosis also. And if you do the microscopic examination, you can see the presence of lymphocytes, plasma cells, and polymorphs also. In chronic diseases, the nodes and the vessels may contain the dead worms surrounded by a fibrotic or calcified tissue. So lymphangitis is a common phenomena. Here the lymphangitis is associated with the swelling, redness, and pain at the site of the inflammation. Usually the lymphangitis is due to the mechanical irritation by the movement of the worms, okay, the liberation of the metabolites, the absorption of the toxic products of the dead worms, or it can also be due to the secondary bacterial infection. The chronic inflammation can lead to the damage, and also the walls of the lymphatic vessels may become incompetent, so that the one-sided flow of the lymph can be become a problem. Okay. So and also the damage will lead to the leaking of the lymphatic vessels, and the high concentration of the protein can be leaked into the surrounding tissue, making the tissue edematous. So the consequence of this lymphangitis and the lymph node fibrosis, and also the associated features like mechanical blocking of the dead worm, or the obliterative endolymphangitis, or the fibrosis of the vessels, these lead to the lymphatic obstruction. So as we know, lymph has to be drained, so that the tissue has to maintain the normal structure. Okay. So the leaking of the lymphatics and obstruction to the lymph flow lead to the accumulation of the proteinaceous material in the tissue, leading to what is called as elephantiasis, or it's also a non-pitting type of edema. You can see all these pictures, they represent different forms of elephantiasis affecting the different structures of the body. So in men, they present with a hydrocele, orchitis, funiculitis, dermatitis, or epidermitis, chyluria, or lymph varices. Okay, and also in females, so elephantiasis of the vulva, chyluria, and lymphatic varices can be found. Occult filariasis is also known as the Meyers-Kouwenaar syndrome. Here, this is actually due to the hypersensitivity reaction to the microfilarial antigens. Okay, so here we can find an eosinophilia of almost 80% of the eosinophils, and if you do the absolute eosinophil count, the count will be more than 3000 per microliter of the blood. So there can be a generalized lymph node enlargement, hepatosplenomegaly, and pulmonary symptoms can be there, which I am going to explain in the next slide. And also the microfilaria released are destroyed in the tissue to form an eosinophilic granuloma, or eosinophil granuloma, sorry. So the classical filariasis and occult filariasis have some distinguishing features, so which may be helpful in the diagnosis. So usually the classical filariasis is due to the developing worms. It can be due to adult worm or the microfilaria. Occult filariasis, most of the times it's due to microfilaria. The basic lesion is nothing but the acute inflammation surrounding the adult worm in case of classical filariasis, whereas it is eosinophil granuloma in case of occult filariasis. Usually lymphatic system, that is both lymph nodes and lymphatics are involved in the classical filariasis, whereas the along with the lymphatic system, lungs, liver, spleen, so many organs can be affected in case of occult filariasis. Microfilaria, usually they are present in the blood in case of classical filariasis. Because they get stuck in the tissue, the microfilaria will not be found in the peripheral blood. Therapeutic response, if you see, the occult filariasis has a poor response to the treatment with diethyl carbamazepine, whereas the occult filariasis, it responds very well to the diethyl carbamazepine. And serological test, complement fixation test, usually it will be not so sensitive for classical filariasis, but the complement fixing antibodies are highly produced in case of the occult filariasis. That's why it gives a very highly sensitive reaction in case of occult filariasis. So tropical pulmonary eosinophilia, TPE, is a manifestation of the occult filariasis. Usually the condition occurs in children and adult in endemic area. The clinical features, there will be something like malaise, fever, weight loss, respiratory symptoms including the nocturnal cough, dyspnea, asthmatic wheezing can be found. And if you do the absolute eosinophil count, there will be more than 3000 per microliter. And the chest X-ray shows bronchovascular markings or diffuse miliary mottling in the lung fields. And it's very well responds to the diethyl carbamazepine, as I told earlier. So the parasite is distributed worldwide, Asia including India, Africa, Australia, Pacific and South America. Worldwide there are around 120 million cases, and 90% of all these cases are affected due to the Wuchereria bancrofti, and India contributes about 40% of the global burden. So we know the mode of transmission is inoculation by the bite of the Culex mosquito. The laboratory diagnosis, we have to demonstrate the microfilaria. For the demonstration, we can use the blood sample which is collected during the night. So because we know the periodicity of the parasite is between 10 p.m. to 2 a.m. and some books mentions the 4 a.m. also. So during this time the microfilaria will be more in the blood, so peripheral blood circulation, hence it is an ideal time. So if you suspect very low amount of parasites is there, then the DEC provocation test can be done. So here we are going to give a single dose of 2 mg per kg body weight of the diethyl carbamazepine and collect the blood after 15 to 20 minutes. So the chylous urine, exudates of the lymphatics or the hydrocele fluid can also be collected to demonstrate the microfilaria. Usually we are going to prepare the thick smear from the blood and we are going to dehemoglobinize it and stain it with the hematoxylin or gemcitabine and look for the characteristic microfilarial morphology. And also microscopic mounts of the anticoagulated blood can be done, and here we are going to see the motile microfilaria in the mount. So technique similar to quantitative Buffy-Coat can be done. So we are going to centrifuge the blood sample at a high speed so that the components of the blood is separated, and the tubes will be priorly coated with acridine orange and DTA. So we have to observe the Buffy-Coat portion of the tube, so where the microfilaria will be residing. We can also do the acridine orange staining of the slides, and if you suspect the light infections, then we need to concentrate the blood specimen. Okay, so if in the viva voice in the parasitology discussion, so after you answer all the questions related to stool concentration techniques, so generally the examiners tend to ask the concentration techniques of the blood. Okay, there you must answer these points. So usually we may go for membrane filtration or centrifugation, as I told earlier, sedimentation techniques, and knot concentration method. Actually, knot concentration method, here we are going to add 2 ml of the blood to 10 ml of the 2% formaldehyde and allow it to settle for around 20 to 30 minutes, and then the sediment is examined for the worms. Okay. So, and also we can detect the adult worms by doing the biopsy of the lymph nodes. Immunodiagnosis, actually it plays, generally it is not recommended for routine diagnosis of the conditions. If you strongly suspect the filariasis, and if you are not finding any microfilaria in the peripheral blood, then the antigen detection in the serum by enzyme immunoassay can diagnose the condition. And in case of occult filariasis, so we can detect the complement fixing antibodies in the patient serum. Of course, polymerase chain reaction is going to help us to differentiate between the different filarial species, and also it establishes the diagnosis. Treatment: the diethyl carbamazepine is the drug of choice, and DEC is given at a dose of 6 mg per kg for 12 days. So it kills the microfilaria but no action on the adult worm. And prevention is, we are going to control the vectors by spraying the residual insecticides such as the DDT or malathion, etc. So you can spray the film of oil over the water surfaces so that the pupae of the mosquito will not breathe, and they will be suffocated in the water. And also we can add the biological controls in the form of adding the larvivorous fish to the ponds, and also the open drains, septic tanks, soakage pits, the flood pits of the latrine should be adequately maintained. So as a part of prevention of the filaria, the Government of India has launched the National Filaria Control Program in 1955. Here the coverage of the program is very less, around 10% of the urban population is covered, leaving out the majority of the rural population who are at risk. Here the program strategy is, you are going to detect the parasitic carriers by doing the night blood surveys, and the larval culture of the vector mosquitoes is done, and you are going to give selective therapy for those who are infected by giving the DEC at a 6 mg per kg per day for 12 days. So this is going to finish the Wuchereria bancrofti session. So if you like the video, please subscribe. Please press the bell button to get notifications of my future videos. Thank you.